today, some insights into how to help people with suicidal thoughts survive and thrive. The challenge we have is the narrative that we have been having around suicide. In the United States, we saw a really significant national dialogue that occurred after Robin Williams' death, and with the deaths of Kate Spade and Anthony Bourdain that only intensified. But the material conversations we have around suicide are around the deaths. We ain't putting forth stories of hope and recovery. And I believe that's where the real opportunity for growth and development and real change lies. David Covington is the CEO and President of Recovery Innovations International in the United States, and he's one of the founding fathers of an initiative called Zero Suicide in Healthcare. Around 40,000 people a year now die by suicide in the US. While we had attention to an increasing death rate in the US as of recently, we've got largely the same situation that we had many years ago. If you go to the mid-70s, we were nearing the 500th death on the Golden Gate Bridge. And at that time, researchers David Rosen and a few years later Richard Saiden did a number of interviews with individuals who the very few who had survived a fall from one of those bridges. The second study looked at people who had been negotiated off the bridge or wrestled off of the other side of the rail. And what we found is, contrary to our notions, 19 out of 20 individuals were either still alive or had died of natural causes over the years. So those stories of individuals who found some way to cope, to hang on, to find a way through, and in some cases to thrive, actually, in some cases to take that experience and use it to become something they wouldn't have been otherwise. Those stories haven't been told, and we think telling them transforms not only the dialogue that we are having but gives hope to people out there who are in pain. Covington is a pioneer of the zero suicide healthcare model. It's the belief that robust improvement in healthcare will reduce the number of deaths. The goal is to prevent death by suicide within the system. There are now hundreds of zero suicide programs in the United States, England, the Netherlands, Canada and New Zealand. David Covington describes one of these programs which has been going for about a decade. We are seeing a model in Phoenix, Arizona, where last year 23,000 individuals were in such crisis that law enforcement was engaged. Someone called the 911 medical system, a family member called the police, the person themselves was so afraid that they reached out. In the rest of the country, every single one of those 23,000 would have gone to a hospital emergency department where they would have waited to get into a room. They would have then waited for some kind of psychiatric consult or assessment. Then would have waited for a referral to get into some kind of program somewhere, and then they would have waited for transportation to that program. All of that waiting would have landed up in a wait of 18 hours to 3 days, depending on where they lived. A new idea in suicide prevention is that you need to have multiple layers, and that they perhaps all have to interact simultaneously. So we have to have health changes, we have to reform our health system so they look after people, say after an emergency visit. But also we need a community response, and we also need a longer-term response. So, for example, we need prevention programs in young people because we want to reach people before they reach that point where it's much more difficult to intervene. Around 60% of suicides are unheralded, so we really need to be acting way before people really get to that point. Look, I think there's a lot of mixed feelings that people experience when they're at risk of suicide, so they don't actually want to tell anyone, even though when they do it is a relief. We know many people do visit a GP prior to a suicide attempt but don't actually talk to their GP. They don't want to discuss how they're feeling, for various reasons associated with shame. And at a certain level, I think when you talk to people who've been in that situation, a sort of self-hate and unworthiness. So it is really difficult. But I think a lot of things can make a difference to that. So, for example, talking about suicide is not a harmful thing to do. Raising it with people. We've introduced a program called Step Care in general practice, which is using tablets and other mobile devices for people to screen themselves before they go into a GP, and that information is then put in the console of the GP before the person goes in there. So even if you've got the flu and depression, then that can be picked up. So it's a way of beginning a conversation. And the person themselves gets their own results, so they can say, look, maybe things aren't going very well for you at the moment. Would you like to make another appointment? Can I refer you to somebody? So it's actually by creating these systems, if you like, you're able to actually identify people who in some ways won't identify themselves but may be amenable to having a conversation about their mental health. In that sort of situation, we have been working on 2 sets of research programs. The first is trying to see what we might be able to detect using smartphone technology, because as we just discussed, we don't know who is at risk. So is there something in the smartphone that's going to give us some indication that people may be at risk? So we can look at things like blogs. Can we tell if somebody is at risk or becoming depressed or becoming more suicidal by what they are blogging? Does voice analysis work? Can we tell an emotional state of a person from that? We are also looking at things like the extent to which we can map social networks using the Bluetooth capability of the mobile phone. So all of this is a bit blue sky, but essentially that's the future, I think, in being able to use something that people carry all the time around with them as potentially a marker for themselves identifying or other people identifying that they may be at risk. The other half of this research program that we are talking about is where we are developing a number of interventions that might work in particular systems to help people who are suicidal and who may not be in contact with health services. So one that we are developing a bit further is something called Living with Deadly Thoughts, which is an online program which basically teaches anyone how to manage suicidal thoughts, which is in final testing in a second randomized controlled trial which is looking at how to change people's distress levels in indigenous communities, and so reduce depression, anxiety and suicide ideation. And that's very exciting, because that was really developed by the community for the community, and our role really was to say, well, this is the way you can put some psychological principles in there. Psychotherapy does work for suicide ideation. Can we convert that into an internet area? People don't get looked after very well after they leave emergency or after hospitalization. So Raft is something that they get put on their mobile phones. It text messages them and delivers them psychological modules, and basically it keeps them engaged with the team after a suicide attempt or self-harm episode. The Black Dog Institute takes an evidence-based approach, and their suicide prevention tools are evaluated in randomized controlled trials. Another strategy they've developed is known as means restriction. It looks at how we can put barriers in place to stop people taking their own lives. It's valuable to consider where most deaths by suicide occur in each community. We have developed a system at Black Dog where we pull together all the different data from most of the national data sets in terms of where people die by suicide, and we combine that with Australian, which allows us to plot where people die. And then, we can also look at that in terms of, is that an increasing factor that's happening there, or is it decreasing over the last 10 years? We are able to separate whether people are near their homes or away from home, and when we look at the away from home data, that tells us where people might be attracted to go to die because other people had died there or because there's not very good security there. So if you look at that in different community places, you can say, wow, that looks like those deaths are happening there. What's happening there? Is that a railway line? Is that a bridge? Is that a cliff? Let's do something about that particular area. And so you've got a very strong focus within a local community that can't be dictated by a general principle about what to do. So I think that's a really key thing. When we have data, we can do an awful lot. We can be more if you're worried that a family member, friend or colleague is having suicidal thoughts, we suggest that it's best to start a conversation about it. I guess the first thing I would say is actually talk to these people and raise it. There's no harm caused by raising a discussion around suicide, and then encouraging them to seek help. Even taking them to see somebody can be really an important thing to do if they are willing to go. Keeping in touch with them, making sure that community agencies know that they might be at risk. It depends on your relationship with a person, doesn't it? So within workplaces, I think it's really important for managers to be trained in being able to identify who might be struggling and to be able to have the conversation. There's many things that can be done at every level. And I think that's why the Lifespan Suicide Prevention Project that we've undertaken is multifaceted, everything from schools to how people are looked after an emergency, because suicide is complex, there isn't necessarily any one cause, and we really have to create these safety nets around people and our community.